So, hi everyone. At the onset, I would like to thank the organizers for giving me this opportunity. So, I'll be predominantly discussing about avelumab and axitinib in the context of personalized treatment in the era of immunotherapy. It's a Merck-sponsored session, so predominantly I'll be talking about this combination based on the Javelin RCC trial. So we've heard the previous speaker illustrating very nicely about how IO has changed the way we managed RCCs, and it was very clearly illustrated about the combination of Nivo EP, one of the earliest trials which has shown a significant long-term outcomes of nearly two-thirds patients doing great at 5-year mark, which has one of the longest trials. But of late, we've seen more combinations of IO with VEGF TKI, which even in the 2022 space, we've seen one combination of Etizo, cabozantinib, which has taken up in this space. And predominantly, we are moving in a space where we are incorporating IO and VEGF TKI in most of our patients. mTOR inhibitors usage has come down significantly, and VEGF TKIs as a single agent are predominantly limited either in the second line or more, or in patients who are financially not affordable in our practice. So moving on, how do we manage a patient with advanced RCC to begin with? Like clearly discussed, we have two ways of managing these patients, considering there are no financial constraints. One is an immunotherapy combination, though there are two different immunotherapeutic options. One is the PD-1, PD-L1 blockage. Next is the CTLA-4 axis blockage, which was predominantly one of the first trials to evaluate, was a Checkmate 214, but from the first phase 3 trials. And it was very clearly discussed in the previous talk. The other option is combining immunotherapeutic agents with tyrosine kinase inhibitors. Now, these are the earlier trials. The first one, which was published, was a Javelin Renal 101 trial, and the Keynote 426, which were published in 2019 in NEJ. Both articles were published in the same edition. And that is where following which there were multiple other trials like the Checkmate 9ER and the CLEAR trial, which were again evaluating the combination of VEGF TKIs with immunotherapeutic options. So how do we choose these one of these agents? Now, first, IO versus IO VEGF TKI combination. So what, as very clearly illustrated, if you have a patient with low disease burden and where young patient where we would at least hope for cure in these group of patients, we would probably start with IO combination. But the inherent problem with an IO combination is late separation of the curves, and nearly more than 1/3 progress within the first 6 months. So this probably is not an option in patients who have large tumor burden, high risk of rapid deterioration. In these group of patients, we would like to see that they respond early, and this response sustains for a longer time, though not as high as what we see in an IO combination, but we see nearly 1/3 of the patients do well even with VEGF IO combination. So probably most patients who present in our practice, I would definitely err towards combining VEGF TKI with an IO drug. Now, how do we choose among these agents? I mean, which is the combination which we would be choosing? So like discussed earlier, there are some complications which are very peculiarly seen with immunotherapeutic agents, some which are very peculiar to VEGF tyrosine kinase inhibitors, and there are a lot of overlapping side effects. No, in reality, how do we manage these? If there are an overlapping side effects like rash, diarrhea, hepatitis, hypothyroidism, or other symptoms, we would first start by stopping VEGF TKI, see how patients cope with it, continue immunotherapeutic agents. If there is a response and the side effects come down, we hold the TKI and continue IO combinations. So for this, we would probably choose a TKI with a shorter half-life. If there is no improvement in symptoms, we would continue the VEGF TKI and stop IO if the patient has grade 3 or 4 immunotherapy-related side effects. So axitinib has one of the shortest half-life, about 2.5 to 6 hours, whereas cabozantinib has one of the longest half-life, nearly 4 days. Now, coming to lenvatinib, that is another combination which has shown highest response rates and consistent response, consistent benefit of treatment irrespective of the IMDC risk group. But as illustrated earlier, the problem with lenvatinib is the dose here required in the CLEAR study was 20 milligram. So can we get away by starting a lower dose of lenvatinib like we routinely do in hepatocellular carcinomas based on weight? Now, this was a very interesting phase 2 study which compared whether a lower dose of lenvatinib this was a US FDA mandated trial where they evaluated if a lower dose of lenvatinib is as efficacious as a higher dose lenvatinib, that is 14 milligram versus 18 milligram. It was seen in this study that there is a dose dependent response, and based on this study, they concluded that 18 mg lenvatinib is better in second line as a single agent. So dose reductions is not advised, and if we start at a dose, it is better to adhere to the clinical trial dosing for most of these agents. So this brings down the option to two agents, that is pembrolizumab axitinib and the avelumab axitinib. So which of these agents would we choose? Again, these are cross-trial comparisons, and what eventually happened in the Keynote 426, there was no stratification based on PD-L1 levels in the study, whereas in the Javelin 101, only the initial analysis, which I'll be discussing in the later slides, predominantly the initial analysis was PFS in the PD-L1 positive subgroup. But just as a reminder, RCCs are one of the tumors which are most immunogenic and have a wonderful response with immunotherapy agents. Nearly 2/3 of these patients across all studies have high PD-L1 expression. Now, coming to Keynote 426, eventually there were more immunotherapy-related adverse events, higher usage of steroids, and this combination is not yet approved in India. Now coming to the Javelin 101 data, it is currently approved in India, lesser steroid usage, lesser pneumonitis, and the safety is one of the best safety parameters were achieved with the Javelin study. Overall survival, though the cross-trial comparison is a busy slide, it can be seen that combinations of avelumab axitinib or pembrolizumab axitinib have one of the best overall survival. But again, these are not recommended to take any clinical decisions because these are cross-trial comparisons. Now, coming to side effects, which are discussed in the earlier presentation, side effects are one very important factors which we would consider while starting therapies in our patients. And axitinib avelumab combination is one such regimen which has lesser treatment-related deaths, lesser corticosteroid use, thus lesser dampening of the immune activation that happens with these agents, and lesser discontinuation of therapy. So this is one of the combination which has the least discontinuation of IO drugs, and lesser pneumonitis and other immune-related adverse events. Now, coming to the trial in detail, it included previously untreated RCCs with clear cell component, and also few patients with sarcomatoid variants were also included in the study. They were randomized in a 1-to-1 fashion based on and stratified based on ECOG performance states and geographic region into avelumab and plus axitinib versus sunitinib alone. The primary endpoint was PFS and overall survival in PD-L1 positive subgroup, which accounted to nearly 2/3 of the patients enrolled into this study. And the key secondary endpoints were PFS and OS in the overall population. And we all know why would this combination illustrate an additional and super additive benefit. One, because the immune barrier which the tumors create include both PD-L1 and also aberrant angiogenesis causes decreased T cell influx or trafficking into the tumor. Combining PD-L1 agents with VEGF inhibitors cause the immune milieu to become more they're more open to immunotherapeutic agents, and they become more immunogenic response. There is more immunogenic response. Now, coming to the PD-L1 versus overall population, they are more or less well balanced between both the IO VEGF combination arm versus sunitinib. 2/3 of the patients belong to the intermediate group, and 16% of the patients belong to the poor risk group in both these studies, and 20% of the patients were good risk subgroups. Now, what was seen was in the primary analysis, the median PFS, there is almost a 5.4-month increase in PFS and a 33% risk reduction in the risk of disease progression or death. That is an improvement from 8.5 months to 13.9 months was seen in this median PFS. And irrespective of the age, the benefit was consistently present with the VEGF TKI combination immunotherapy agents rather than sunitinib alone. So age is not, there was no difference in the overall response rates or median PFS in patients who were aged more than 75 years. Now, coming to the difference of efficacy based on a favorable versus intermediate and poor risk group, no difference was seen, consistent benefit was seen with avelumab axitinib combination compared to sunitinib across a favorable, intermediate, and poor IMDC risk groups. Though the benefit was more in the favorable group, the difference, the hazard ratios were not clinically significant. Now coming to as we can see here, consistent benefit was seen in all groups. Even the PD-L1 positive group had greater benefit, whereas the PD-L1 negative, it did touch the margin but favored the avelumab axitinib arm. Now coming to response rates, as we can see, combining two agents from two different classes like IO plus VEGF TKI, there was an increase in partial response rates and complete response rates. Whereas in single agent VEGF TKI, we see most of the patients having stable disease rather than partial complete responses. Later, how fast are these responses and the depth of response? As we can see in these curves, the median duration of response, or the best median duration to get a response, is 2.7 months. So this again, as we can see in the Kaplan-Meier's curve, like discussed earlier, the problem with IO agents is the median time to response is best with VEGF TK IO combination rather than IO combination, and is least with sunitinib. So in sunitinib, for achieving a median time to response is 4 months, whereas it is nearly half, that is 2.7 months in VEGF TKI plus IO combination. Now coming to PFS2, how do these patients fare after they progress on immunotherapy? The PFS2, there is almost a 45% reduction in the risk of disease progression or death after the second line. So this is consistently seen even in non-small cell carcinoma lung, in RCCs, in HCCs, that immunotherapeutic agents, if are being planned to be incorporated into treatment plan, the earlier the better, because there is a sustained benefit which is clinically depicted in PFS2 in these studies. Now coming to high-risk histologies like the sarcomatoid variants or the sarcomatoid component in RCCs, this combination continued to show benefit even in this population, where nearly all 50% of the patients either had complete response or partial response compared to single agent VEGF TKIs. It is now proven that in patients who have sarcomatoid histology, either an IO combination or a VEGF TKI plus IO combination would definitely fare better than a VEGF TKI alone in this high-risk population. Now, coming to what subsequent treatment did patients receive, because the fewer number of patients progressed on this VEGF TKI plus IO combination, only 31% of the patients in VEGF TKI received subsequent treatment compared to 51% in the VEGF TKI alone arm. Whereas most of these patients, that is nearly 35, means 1/3 of these patients, even in the subsequent lines, received immunotherapy in the sunitinib, that is single agent VEGF TKI arm. Now it is again like I reiterated previously, PFS2 benefit as seen, it is always better to incorporate IO combinations or IO agents in the first line rather than the subsequent lines. Now, just to conclude, as it was seen in the avelumab axitinib, there is a longer median PFS. I've not discussed the OS because it is still immature. This consistent PFS benefit was seen both in the PD-L1 negative and in the PD-L1 positive arms. There is a nearly doubling of the response rates was seen, nearly half of, for the median time of response to achieve, it was nearly half, that is 2.7 months versus 4 months, lower discontinuations and lesser corticosteroid used compared to the other agents. So other trials which are currently, which were previously or are currently being analyzed are the Checkmate 214, Keynote 426, the Javelin, Checkmate 9ER, and the CLEAR study, which is pembrolizumab and lenvatinib arm, lenvatinib group. More or less, there is a consistent hazard rates for PFS, that is 0.522 to 0.74. No PFS benefit was seen in the Checkmate 214, but a significant overall survival benefit was seen in the Checkmate 214. Whereas Javelin is probably a middle ground in patients who are frail, patients who are elderly, in patients who are a little worried about side effects. Probably this combination of avelumab axitinib is the right fit. And in patients who have a high disease burden, who are young, probably I would err towards giving the pembro lenvatinib combination. And in patients who have a lesser disease burden and who are young, and where I would like to have these patients cured and disease-free for the longest period, I would err towards the IO combination. Thank you.
Thank you, sir. Thank you for the wonderful presentation. And next